Thank you for joining us today for this discussion on strengthening mixed health systems. My name is Cicely Thomas, and I'm a program director at Results for Development, and I lead our practice on mixed health systems and public-private engagement. Before we get started, I want to go over a few details related to technology in this webinar. So first of all, we are recording the webinar, and we'll make that available to everyone on the website, and we'll be sending that around after the webinar today. We've left some time at the end of this webinar for discussion, and we hope you'll engage in that. We encourage you, as you're doing already, to actively use the chat function. Feel free to pop in questions and comments. We'll be sure to monitor that throughout the discussion today. My colleague Lee Fredmond will pop his email in the chat right now. You can feel free to reach out to him if you're having any technical issues. During the discussion section at the end of the webinar, we will encourage you to raise your hand, use the raise your hand function, and we'll be happy to call on you. Please also switch on your camera if you can at that time, and your audio, and introduce yourself. We want to use this as well for a networking opportunity, and we really encourage you to share your email with colleagues if you're comfortable in the chat. So now we'll turn to the content for today's webinar. Next slide, please. We'll start by introducing our team and the approach that we've designed and implemented to support public-private engagement in mixed health systems. Next, we'll introduce the public-private engagement ecosystem that has come out of our work, and we'll talk a little bit about the learnings from all of this work, and then introduce some of the tools and new guidance for public-private engagement. Finally, we'll propose a few ideas and implications that this work has for the future of public-private engagement and mixed health systems. And then we'll open up for discussion for about 20 minutes to hear from you about your questions and comments, and hopefully have a good discussion about how we move this field forward. Next slide, please. I'd like to quickly introduce our team that's on the line today. R4D designed and implemented the project in close collaboration and through 2 local organizations. My colleagues from R4D are pictured here on the slide, and you'll be hearing from them today. But we believe that support for mixed health systems at the country level should really be fit for purpose and responsive to a set of shared, validated country population health needs and demands, as expressed by the health system actors themselves. And that to support those needs, we think that local experts are really best placed to provide that support because they're deeply integrated in the context and understand it and can be present to provide consistent assistance throughout an engagement. So R4D partnered with Insight Health Advisors in Kenya, and our colleagues, Drs. Nelson Gatanga, Walter Obita, and Lyndon Marani are on the line, and we'll hear from them today. And we also partnered with Access Health International in India, and our colleagues Jadev Anand and Malik Chokshi are also on the line today. Welcome to the team. Next slide, please. So our approach and work aim to build the evidence around the importance of strengthening mixed health systems to achieve universal health coverage. We know that most health systems are mixed, meaning that both the public and private sectors provide key services, and that within those mixed health systems are public-private engagements. Public-private engagements, at least defined by the IFC, are deliberate, systematic collaboration of the government and private health sector according to national health priorities, so sort of beyond individual interventions and programs. And while there's this growing global consensus that achieving universal health coverage and the sustainable development goals will require some combination of strong public stewardship of mixed health systems and an engaged and organized private sector that provides high quality, affordable health services, what we see is that there's not a lot of evidence on how to ensure strong public-private engagements are successful and sort of support this optimized and high-functioning mixed health systems. And this is really where our work comes in terms of understanding the how of public-private engagements, including the complex network or ecosystem of helping and hindering factors surrounding a public-private engagement, and the kinds of approaches that can be used to strengthen them. Next slide, please. So with support from the Merck for Mothers initiative, we designed a project with local partners that would support governments and the local private sector to demonstrate and document practical and actionable processes for integrating quality private maternity care into government stewarded health systems. We completed field activities in Kenya and India, as well as global learning activities that we'll be sharing today, including a systematic evidence review, secondary case studies, and development of knowledge products, including some guidance and tools to accompany the learnings around public-private engagements. Next slide, please. So as part of the work, we identified 3 research questions that are described here. And we really wanted to understand, firstly, is the approach of supporting public-private engagements to strengthen maternal and newborn health and universal health coverage associated with outcomes, including improved quality of the actual engagement itself between the sectors, as well as improvements in relative and relevant health service outcomes? We also wanted to understand more about the factors that are associated with helping to achieve intended outcomes, and also the factors that are associated with hindering engagements. And then finally, we wanted to understand more about what engagement brokers can do to facilitate these factors that help engagements, mitigate factors that hurt them, and ultimately help engagements achieve better health outcomes. So to answer these questions, we conducted several activities which fed into these questions sort of to varying degrees. So we worked on, as I mentioned, an evidence review, some primary and secondary case studies, secondary case study cross-cutting analysis. And then we also conducted implementation support in Kakamega County in Kenya and in Maharashtra State in India. Next slide, please. So as part of the work, we designed and implemented a facilitation approach for public-private engagement that recognizes that both health systems, so these environmental factors, are important, as are strengthening the relationships amongst public and private actors themselves. And a key aspect of this facilitation approach is the role of the trusted broker to steward this process. So the approach really aims to optimize the relationship and collaboration between the 2 sectors, moving from a state that you see on the left, where there's a lack of alignment between public and private providers. So maybe this looks like mistrust between the sectors or missed opportunities for leveraging private sector to improve health outcomes in a country, to the state that you see at the right of the slide, where there's better alignment and collaboration. So where there's improved trust and public-private sector recognizes and acts on opportunities for optimizing their work by leveraging each other. So each step in this process builds trust between the actors and creates an environment for open and honest engagement. And the aim is to then leverage that trust and work together on assessing challenges with both engagement between the sectors, as well as challenges in the health system itself, and then jointly designing solutions to address those challenges, and solidifying and sustaining that trust through continuous learning, joint implementation, and adaptation based on what's working and what's not working. So as part of the work, we also employed a continuous monitoring, adaptive support, and learning approach. And that helped us adapt and improve as we went along, and also helped us fill the gap in evidence that exists around public-private engagements. Next slide, please. As part of the learning approach, we ended up reviewing about 101 articles in the academic published literature. We conducted 2 primary case studies in Kenya and India, as well as 6 secondary case studies. And today we'd like to share the findings from this work with you. So to do so, I'll pass it over to my colleague, Chloe Lanzara, who will share some of these findings. Chloe, over to you.
Thank you, Cicely, and hi, everybody. So as Cicely described, we conducted a literature review related to public-private engagement in maternal health. And we were in part looking for evidence around the factors that can help or hinder the success of a PPE. So in the literature, we identified many references to what one might think of as the common hard or nuts and bolts factors of PPE, so things like contracting mechanisms and regulation. But what we didn't expect was that the literature also pointed to the importance of the dynamics and interactions between public and private stakeholders, or in other words, the soft factors that sometimes go overlooked. So together, this evidence and our own experience suggests that while the hardware of PPE are important, equally important are the relationships, dialogue, and collaboration between sector actors themselves. And building on these findings, we brought these hard and soft factors together into a more holistic framework that describes a public-private engagement ecosystem. This ecosystem consists of 3 factor sets: environmental, structural, and engagement factors, as well as what we call a validated health system gap. Starting from the outside in, the environmental factors shape the operating environment for a PPE. So they include the economic and financial context, for example, the public financial management system, legal factors, including relevant laws and regulations, the political context. So for example, is there high-level political support for PPE? And finally, organizational factors related to how the health system is organized. So is it decentralized? Are private providers fragmented, or are they organized in some way? We recognize that the individual actors within a PPE likely have little direct influence over these environmental factors, but at the same time, they might impact the engagement's effectiveness, and so we think they should be considered. Next up in the ecosystem, we have the validated health system gap. So this isn't exactly a factor in itself, but it refers to the identified health system problem or challenge that public-private engagement is looking to solve. This gap should be evidence and demand-based and validated by health system stakeholders. Our next set of factors are the structural factors. So these determine the architecture of a PPE, including the type of engagement model. So for example, whether it's bilateral or multilateral, how formal the engagement is. So does it use an MOU or some kind of formal contracting mechanism between partners, and the available financial and non-financial resources to implement the engagement. And while these structural factors are intimately related to the operating environment of an engagement, we've defined them as specific to the engagement itself rather than the broader context, in that the actors within an engagement have some direct influence or control over them. And this brings us to the core of the PPE ecosystem, which are the softer engagement factors, or the capacities, relationships, and interactions between public and private stakeholders. You'll see that we've further broken down these engagement factors into 2 dimensions: foundational and operational. Foundational factors are central to the relationship dynamics and interactions between the public and private sector actors, including their level of trust in one another, their mutual understanding of each other's roles and motivations, and their willingness to expend time and effort engaging with each other. And building on this foundational dimension, the operational factors support the overall functioning of a PPE. So these include the overall goal for the PPE, as well as the knowledge and skills of the partners, and of course, the communication and accountability mechanisms that support day-to-day operations. We think that without meeting a minimum threshold on the foundational dimension, so overcoming mistrust and resistance to engagement between the sectors, it's unlikely that a PPE will be able to operate effectively. And at the same time, operational factors like communication can help to improve or erode that foundation of trust and understanding over time. So we therefore believe that the foundational and operational dimensions run in parallel to each other and can be linked in a virtuous or a vicious cycle. So given all this, how does a trusted third-party broker fit into the PPE ecosystem? We see a trusted broker as having a key role to play in helping public and private sector partners move through the system strengthening process. A trusted broker is an individual or organization whose goal is to help public and private actors work together to advance their goals in a neutral way. And they can help actors in a PPE by fairly representing their priorities, supporting them to come to consensus, and helping to set up processes and structures for continued engagement, or in other words, ensuring that the factors ecosystem is as facilitative as possible. So that being said, public and private sector stakeholders and the actors and donors who support them often ask questions like, what is the right structure for public-private engagement? And so you might be wondering that as well, so what? Why do we need another conceptual framework? Does it help us to answer this question? We think that while there isn't a blueprint that will ensure successful PPE, we believe a more holistic approach to PPE in health is needed. And so this ecosystem encourages consideration of a range of factors and their interconnectivity when designing and implementing PPE. And we hypothesize that if practitioners consider these different factors and design their engagement solution to fill a validated gap in the health system, then the engagement may be more likely to be successful. Next slide, please. Next slide. So now that we've learned about the background of the project and the foundation of the PPE ecosystem, we'll turn to our key learnings from the project, starting with our question on whether PPE can improve outcomes. In our evidence review, we found that only a small fraction of studies focused on PPE for maternal health actually measure outcomes in a rigorous way. And of those, most focus on high-level beneficiary health outcomes. So from those studies, we found that there are some early positive signs that PPE can be associated with improvements in health outcomes, which we see as a signal that PPE is worthy of further exploration and investment. However, we also found that the effectiveness of PPEs relies on triggering a chain of interrelated outputs and outcomes, and future research should look more closely at those connections. So while many of the studies we reviewed showed positive outcomes, we also know that not all engagements are ultimately successful, and it's important to ask ourselves why. There's a lot we could learn from less successful engagements if we also had evidence about other outcomes within their theory of change that may have been necessary to improving health. So for example, if a PPE doesn't reduce maternal mortality, do we know whether it did increase facility births or decrease patient costs? Where along its chain of outcomes did it break down and why? And our review of the evidence suggests that research on PPEs could provide greater insight if focused on that larger theory of change driving a PPE rather than focusing only on high-level, longer-term health outcomes. Related to this, external support should seek to strengthen and generate evidence on how PPE supports health system outcomes. So as mentioned, the existing research often focuses on whether a PPE impacts high-level health outcomes, such as mortality. However, the ultimate goal is to improve those kinds of health outcomes, but PPEs are really designed to address gaps in the health system. So for example, through policy or operational reforms. And given this, we think that both the design of PPE and the research that helps us understand whether it's working should take a stronger systems approach, looking at other types of system and engagement outcomes as part of that broader theory of change. So overall, there are certainly gaps in the existing evidence base around PPE outcomes. And while there are positive signs, we need a lot more research and rigorous evaluation of public-private engagement. But our own primary research did produce some additional key learnings around PPE outcomes that can help to start filling in some of these gaps. So first, we learned that at least in the time frame of our research, changes in engagement outcomes related to the strength of the engagement between sectors itself were more apparent than changes in health-related outcomes. So in Kenya, public and private stakeholders co-designed a set of actions, some focused on public-private engagement and some focused on health. And by the end of that project, we found that they'd made significant progress on about 2/3 of them. But we observed relatively more progress on the actions that were focused on improving engagement between the sectors rather than actions focused on health outcomes. So for example, significant progress was made on forming a private sector association in Kakamega County to better enable private actors to engage with the public sector. We have a few hypotheses for why this was the case. So on the one hand, health outcomes are longer term and require more time to move the needle. But we think it's also likely that engagement outcomes are foundational to improving health-related outcomes through public-private engagement, meaning that prioritizing improvements in how the sectors work together creates greater potential for health improvements in the future. And so finally, given that COVID-19 began midway through this project, we also learned quite a bit about unexpected external shocks. Obviously, you can't always predict when a shock will occur, but what you can do is expect that PPE are likely to face some changes over time, and you can provide resources that enable flexibility and adaptation. We think that starting PPEs with this in mind and planning for how adaptation can be managed and resourced is likely to improve the potential that engagements successfully weather shocks and can leverage the opportunities that might arise from them. So on that note, we also learned that shocks can have effects both bad and good, and that in some cases they can actually strengthen PPE outcomes. So in the Kenya engagement, for example, that engagement experienced many shocks, not only from COVID-19, but also from political transitions and a medical workers' strike. And while these were certainly challenges, we found that evidence that public and private partners utilized these shocks to actually strengthen their engagement. So the pandemic incentivized sector actors to reprioritize and work together, and the medical workers' strike may have helped to actually strengthen the referral system between the public and private sectors. And we think that by strengthening the engagement between the sectors, these actors were better enabled to leverage opportunities to work together afforded by these shocks. And we ultimately found that some engagement factors like willingness to engage and trust may have actually improved over time as engagement outcomes. So we'll now get to hear reflections on outcomes and adapting to COVID-19 in Kenya from Dr. Ruth Kapenga, who is a key member of the Kakamega County Health Management Team involved in implementing the Kenya engagement.
With the help of the project through Dr. Marani, we were able to come up with a COVID-19 steering committee, for lack of a better word. It was where we had private sector represented there in the non-governmental organizations were represented and also government side. And so this subcommittee, mostly the role was to look at how to mobilize resources between the different players, and then also how to respond more efficiently and effectively. As you may be aware, with the government side, there's usually a lot of bureaucracies when we have to do most of the activities. So through this subcommittee, a lot of resources, both and items were procured from the different players, and that was very helpful. Secondly, we were able to know the challenges that were on the private side. When we started our response, it was more, the private sector was, for lack of a better word, blindsided. So the government side was running with everything, trying to ensure this and that were in place without actually taking into consideration that some of these COVID patients are going to be seen in the private sector. So having the private sector on the table, on the discussion table, was very important because it helped us to see that even the private sector needs to be supported in terms of capacity building, supported even in terms of commodities and all that. And as a government, from that interaction, we were able to support training of some of the health service providers from the private sector, more specifically from the faith-based organizations.
Many thanks to Dr. Kapenga for those reflections. I'll now hand it over to my colleague, Courtney Tolmie, to share more about the project's other learnings.
We do want to move forward. So the second research question that we looked at was focused on the helping and hindering factors for public-private engagements. So why does this matter? Well, as Chloe shared earlier, there's good evidence, and we've uncovered some good evidence that PPEs can improve outcomes. But we also know this is not a silver bullet. There's never going to be one single recipe for how you create a PPE that is effective in improving the ultimate outcomes that we hope to achieve in maternal and newborn health and UHC. And so we wanted to really dig into the factors and the drivers that may help to make PPEs more successful, or understand the factors that may serve as obstacles. So next slide, please. So the first thing that is important to acknowledge is from all of our research, both the systematic review and the primary research that we conducted, we found that all of the factors that Chloe described earlier in the ecosystem showed very clear signs of playing a role in PPE outcomes. So that includes things like the structural and environmental factors that really are more prevalent in the literature and in experience, things like the resourcing of PPEs, the political factors, the regulatory environment. Those things are important, but so are the engagement factors. And we found just across the board with all of the cases we looked at, all of these factors showed up over and over again. One important trend that we observed, especially in the secondary cases that we reviewed, was that the starting point for factors is important. So what I mean by this is that while factors are certainly malleable, if you start with something like low political will, you can move to a place of higher political will. We saw over and over again that cases would refer to where they started with a factor, and over the course of a particular PPE moving forward, implementers and supporters and partners of that work would come back to that starting point and say, well, we started at this level, and that really kind of continued and carried on through the course of the PPE. So this is an important finding for people who are supporting or implementing PPEs, really recognizing that when you're starting this work, that starting point is incredibly important. I've noted already the importance of structural and environmental factors, the hardware that Chloe talked about earlier. But again, what we saw in all of the cases we looked at was that engagement factors, things like trust, mutual understanding, will to engage, all also incredibly important. And one of the most interesting findings that we observed was that not only are all these factors quite important, they're also very interrelated. So to provide a visual of this, maybe we can move to the next slide. So this is a mapping that we developed from the 6 secondary cases we looked at, which reviewed 6 public-private engagements in 5 countries that are listed on the bottom left of the slide. What we did was we reviewed the existing literature as well as conducted some new interviews, key informant interviews with people involved in these PPEs to try to identify what they saw as the factors that were critical to the success or lack thereof of these engagements. And we also tried to understand where there were linkages across the factors. So when was it that an implementer would be interviewed and they would say, well, you know, the formality of the model was very important. And this really stemmed from this issue of mutual understanding at the beginning, things like that. So each of the lines that you see between the different factor groups represents a place where in one of these secondary cases, there was a link between these 2 factors. So this is just a really clear demonstration that there are a lot of linkages across these different factors. And the reason why this is important is that we know that some of these factors are going to be more easy to move than others for different actors. So if we know, for example, as we saw in our research, that there's a really clear link between engagement rationale, accountability, and structural factors, actors can look at those 3 factors and see, are there ones of these that are going to be easier for us to strengthen or work on to improve the overall engagement? So again, really looking towards these very actionable recommendations for moving forward. So next slide, please. So in addition to these evaluation findings and learnings, one of the most important things that we really tried to look at as part of this project was how these findings can be integrated into real public-private engagements, including how we assess where an engagement starts in terms of factors and how we can strengthen those. So to speak a little bit more to this, I want to turn to my colleague Jaidev Anand from Access Health to share how we approach this practical factor assessment for the support we provided for the Lakshya Manyata program.
Great, thank you, Courtney, and hello everyone. So jumping, right into it. In the case of Maharashtra, the team took a stepwise approach to the assessment across the PPE ecosystem model. So this was an assessment of the environmental factors, the structural factors, as well as the engagement factors. Now, starting with the environmental factors, what was put in place is an integration assessment, the rationale for which was done based on the premise that there is a need to understand the broader context within which partnerships are molded, or for that matter, will be influenced by in the future. To really provide the system lens, which can, perhaps risk being overlooked if the focus is confined solely to the bilateral engagement, between the public and private sector. This was considered all the more important in the case of Lakshya, the program in Maharashtra, as this was a subnational program, and there were a host of dynamics at a national and subnational level that would influence its trajectory. So what was the integration assessment? It basically looked at the 4 environmental factors to identify what are those helping and hindering specifics towards the program. And this was done based on, of course, speaking to experts who are very much engaged in public-private engagement, but also really, putting together the widely acknowledged and endorsed strengths and barriers of public-private engagement in India. It was hoped that this integration assessment, would help partners shape, Lakshya moving forward, and really being able to keep these broader context factors in mind as and when the program moves forward. Moving to the structural factors, this was assessed through a one-on-one interviews with stakeholders under the Lakshya program through a list of open-ended questions. This helped us get insight from stakeholders on some of the broader aspects of PPE and how they view such factors contributing to the partnership. The idea of having these questions specifically to the structural factors was to see how they may later align with the engagement factors and how weaknesses in the latter may reflect in the former. So, if you're talking about the sort of foundational or operational elements or dynamics, how does that, impact the broader formality of the engagement or the degree to which it is formalized? Finally, towards the end, we had an assessment of the engagement factors, which was primarily a close-ended questionnaire. This was shared with public and private stakeholders online, of course, because we were very much in the midst of the pandemic. And what it looked to do was, ascertain the degree to which there is agreement or disagreement on specific domains of the engagement factors and where the areas of divergence may arise. A high level of divergence on any one of the factors or sub-factors naturally, signal to us a potential area that may require greater dialogue and collaboration and, areas for further discussion and to be strengthened. In the case of India, partners, for example, had, differing views or divergent views on issues of communication and accountability. With generally the public sector seeing these as less of a problem as compared to private sector. So, already there was the case that there are 2 very different perspectives and, having established that there are these diverging views, how do we then get partners, to come together and really enhance the cooperation, dialogue, and collaboration on how these specific factors can be strengthened? Towards the end, there was going to be a joint workshop where partners were going to come together and really chart out a roadmap or action plan as to how these engagement factors could be further strengthened. This was supposed to be a workshop held in the month of March, but unfortunately, due to the resurgence of COVID in India, and specifically in the state of Maharashtra for that matter, that took a bit of a backseat. However, that said, I think what was interesting to see is that partners truly appreciated this approach, which in the context of India was a very, I would say, innovative approach of looking at things, right? Because you're looking specifically at the dynamics between the sector partners, and that is something that was appreciated to the extent that we also, had recommendations coming in from stakeholders that perhaps this engagement factor assessment is something that could be, done periodically within the Lakshya program. and could, moving forward help, enhance the strength as the program moves forward and contribute to its sustainability. So with that, I'll pass it back to you, Courtney. Thank you.
Great, thank you, Jaidev. So then moving on to our final question, which is really about the approaches that third-party supporters can take to really help strengthen PPEs. So next slide. So one of the first and I think most important foundation setting points that we found, especially in the systematic review that we conducted at the beginning of this project, was that this is really a gap in the literature and in the evidence. When we reviewed the 101 articles that Cicely talked about earlier, what we found was that there was certainly mention of third-party support. There was acknowledgement that there are brokers and are partners outside of the traditional public and private sectors that are involved in mixed health systems. But there was really a gap in terms of any sort of evidence related to how that third-party support can be provided, who provides it, and how that interacts with PPE outcomes and engagement factors. And so based on this, we really wanted to make this a pretty key part of our empirical work with this project. What we found through our primary cases, as well as some additional data collection with the secondary cases, is that third-party support can be incredibly valuable. But again, while we provided and identified some recommendations and ideas for the who, the how, and the when, this remains a big gap that requires much more work and much more action-oriented research. And that includes who should be playing the role of a third-party broker, what sort of approaches they can take to really support PPEs in a way that is very demand-driven on the part of the partners. And also this really important question of when. When should third-party supporters enter? And then also, how can they set themselves up and how can they set up the engagement in such a way that they can exit while still making this successful and sustainable? A third point that came out of our research was the need for flexibility of third-party support. Chloe spoke a bit earlier about some of the shocks that we experienced as part of this project. This included things like the global pandemic, industrial action, so medical worker strikes, as well as a political turnover. So big shocks as well as small shocks like hacking of Zoom meetings. So these are all things that really third-party brokers need to be set up to be very flexible to address. And then the final point here, which is very much related, is that in the process of designing third-party support for PPEs, from the beginning, those that are supporting this type of work should really take into consideration the issue of resources. And that's not just financial resources, but also human resources that might be needed, especially to be flexible to those shocks. And then even things like proximity to the main engagement stakeholders. And this is something we saw in our work in Kenya. We saw from everyone we spoke with that the third-party support provided by Insight Health Advisors was cited as being really important and really valuable for driving this work forward. But it was also acknowledged that, without an office in Kakamega County, there were challenges that the brokers as well as the partners had to overcome. So these are all really considerations to bring into the design of third-party support. So again, moving beyond the formal evaluation and learning findings, we also want to share some perspectives and experiences from our partners in Kenya and India regarding what third-party support looks like in practice and how this can be strengthened. So first, we're going to play a clip from Dr. Lyndon Marani, who is on the line, but this clip comes from an interview that he conducted with Dr. Ruth Kapanga, who you heard from earlier, really speaking to the trusted broker role.
So one of the things probably that a trusted third party has to have is quite a bit of humility, which sometimes I tend to lack. Because you need to be trusted, you need to put yourself in the position where you're a neutral arbiter as well as facilitator. So it's some of what is required is a clear understanding of the healthcare system as is currently situated, and a clear understanding of what the partners need to get to their common goal, and basically just constantly reminding them what their common goal is. And then sometimes wearing the heart of a technical advisor, where you're saying, for you to be able to attain this goal, these are the changes you have to make internally. And then going to the other partner and also doing the same. So for example, for the private sector, if they ever wanted to engage with government, they had to get themselves organized. The government was never going to come and organize them. And for the government, on the other hand, is supporting government because the government itself wanted to set up a partnership, an office for partnership management. So how do we do that? Maybe can I help you with this document? What kind of documents do you need? Can I help you develop those kinds of documentation? So being able to listen and then being able to provide the technical assistance that is required. And then sometimes just putting in the legwork, and if the private sector needs an attorney, making sure you've made those calls so that the lawyer is available, the lawyer is responding to them.
Great. Thank you, Dr. Marani. And so now I'll turn back to Jaidev Anand to speak to the experience in India.
Thank you. So in the case of India, the third-party support was very much necessary and valued, because what the third party did was really bring in key capacities that may be missing in either the public or the private sector. In the case of Lakshimanita, again, the third party served as a mediator that helped bridge sort of the policy thinking within the government and the clinical thinking within the private sector, a role again which was widely acknowledged and valued by the partners. I think that said, as Courtney mentioned, though this wasn't specifically expressed in the case of India, there is a need, to chart out a clear pathway for transferring a lot of these knowledge and capacity to primary stakeholders. Otherwise, there is the risk that retaining institutional memory then becomes challenging. Public and private sector, were able to identify areas through the questionnaire that we shared as to where they may need to strengthen their internal capacity. So that said, I think it would be useful, in this case, identifying what these capacities needed are through the life cycle of the engagement, and putting in place formal mechanisms to build these in over time. Again, to ensure that there's effective knowledge transfer, and ultimately the ownership resides with the public and private sector partners, and really adds the needed element of sustainability. So with that, back to you, Courtney.
Great, thanks, Jaidev. And so moving to the next slide, now that we've had a chance to talk about the research findings and evaluations findings and some of the learnings from this work, we wanted to move really clearly to the practical applications. We designed this project really not just to provide new research and evidence, but to really provide insights into how we strengthen PPEs to actually improve mixed health systems and ultimately work towards UHC. So to speak a bit more to some of the tools and materials that partners can really take up from this work, I'm going to turn to my colleague Daniela Gutierrez to speak to this.
Great, thanks, Courtney, and hello, everyone. So as Courtney mentioned, the project developed several practical tools and resources to facilitate public-private engagement, so a few of which I'll highlight quickly today. So on the next slide is the Public-Private Engagement Resource Compendium. We developed this compendium to systematically categorize and organize the vast amount of existing practical guidance out there on how to achieve effective public-private engagements. And we also included some of the new tools that our project created into the compendium as well. So here's a snapshot of one of the tables in the compendium. It includes, as you can see, the name of the resource, the source where it's coming from, the type, and a description. And the resources in the compendium include some of these larger how-to and primer engagement guides, as well as more specific and analytical tools, as well as some PPE related trainings and even some COVID-19 specific public-private engagement resources that we came across in our review. So in the last column there, you can see that we also mapped each tool to the PPE Ecosystem framework to better understand the tools and how they might be used. And finally, recognizing the importance of the third party or trusted brokers, our project also gathered specific tools and resources for those facilitating or brokering a public-private engagement. So that's the last section of the compendium. On the next slide is the Rapid Health System Integration Assessment that Jadev mentioned. This is another tool we developed that guides country stakeholders to answer important questions related to the influence of environmental factors on a public-private engagement. So considering the political, organizational, economic, and legal context. And the outputs from this assessment are really meant to help both inform the strategic and operational design of a public-private engagement, as well as its implementation, and also to determine its feasibility of it being integrated and sustained within the health system. So the environmental factor spectrum shown here is a condensed version of this larger assessment, and it shows the characteristics of a less conducive to a more conducive environment for PPE. Moving on to the next slide is the third resource we'd like to highlight today, which is the co-creation process toolkit. This is the general process facilitation approach that our project used to support better engagement between public and private health sector actors through trusted brokers in Kenya and India. So during this process, we conducted trust building exercises, we supported partners to identify solutions and resources, and ultimately helped them to co-design and implement an implementation plan that builds accountability mechanisms to sustain the engagement. So based on these meetings, workshops, and tools that we used as part of the country work, we codified this approach and developed this toolkit that includes a co-creation process. And so this, you can see here is the facilitator's guide, a workshop agenda guide, and then here is some sample slides as well as some templates that can be adapted by other country stakeholders interested in recreating this process. So on the right here, you can see a sample implementation template from a plan in Kakamega County. On the next slide is the last resource that we'll highlight today, which is the engagement factors self-assessment tool that Jadev also mentioned. So this tool we developed when we realized there was no existing tool to really assess strengths, capacities, related to the capacities and relationships of both the public and private sector actors. So making sure that we understand those sort of capacities when they're entering or are already implementing a public-private engagement. So this self-assessment tool is a larger questionnaire, open-ended questionnaire, as Jadev mentioned, but that we used. It asks public and private sector actors to rate their level of agreement with a variety of statements to better understand their current performance. And then we look across at those responses in the questionnaire and identify areas of strength or areas of potential improvement that can later be discussed as a group. So this tool particularly is great as a starting point for the co-creation process to gather as a group and then start tackling the challenges that way. And the progression model shown here is a condensed version of this tool. So it's meant to be used in workshops or meetings for a more rapid sort of point in time assessment and get a quick sense of where the engagement stands at that point. So you can also see here that stakeholders score their engagement on a spectrum from emergent to optimal. And so we also noting that performance on these several engagement factors can really vary and may improve or even regress over time, depending on how the public-private engagement develops or evolves. So on the next slide is just a complete list of the tools and knowledge products that our project developed. And we'll put up a link to the website where all of these will be available to you. And we hope you take a look and we encourage all of you to use them or share them with colleagues that may use them in their work. So with that, I'll pass it on to my colleague, Cicely, who will talk about what this all means for the future. So over to you, Cicely.
Thanks, Daniela. And thanks to everyone for rejoining. We really appreciate it, and we can't apologize enough for that terrible disturbance. I want to talk a little bit about the key messages that we think are important to take away from this work and that have real implications on public-private engagement as we think about leveraging public-private engagement for universal health coverage. Next slide, please. So firstly, the evidence does support the importance of public-private engagement for health outcomes. And the evidence does tell us that there is a documented correlation between better engagement and improved health outcomes. I think other important information coming out of this work is that it's really important to think about public-private engagements as they operate in this complex adaptive system, and that when supporting them and evolving mixed health systems, it really requires a systems approach. And this is something that we have really learned and taken to heart in this experience. So I think there's a lot to take into consideration when working to strengthen public-private engagements, from this aspect of the environmental and the structural factors to also these engagement factors that we've spoken about. We also want to recognize that this work, that through this work, that enabling and supporting trusted brokers, these third-party supporters or coaches, strengthens the institutional architecture of mixed health systems. And it's an effective way also for donors and funders to support better public-private engagement outcomes. And then finally, the COVID-19 pandemic has demonstrated how health system shocks can disrupt progress on strengthening mixed health systems and a variety of other things. But I think it also gives us some examples of how better mixed health systems that are really stewarded well, or another way of thinking about this is optimizing the public and private sector, that these systems can be more resilient and adaptive in the face of these shocks. So we also want to recognize that there's more room for investigation and learning. Next slide, please. So for example, there's more work to be done on identifying and showing the interrelatedness of these factors that we've talked about today, and really understanding the stakeholder sphere of influence on these factors. So for example, what level of influence can a public or private stakeholder or trusted broker within an engagement have on system level factors related to political will, for instance, versus influence on the type of memorandum of understanding or contract between the parties. I think another area that we think would be important to explore is the directionality or causality between the engagement factors, between all of the factors really, and the sort of practical guidance on how to most effectively target public-private engagement support. There's certainly a need for longer-term monitoring and evaluation of public and private engagements to investigate the linkages of stronger mixed health systems with health outcomes themselves, given that health outcomes take longer to observe. And then finally, a really important area that we hope will be continued to be studied is this third-party support. Who is the ideal trusted broker? What is their profile? When should they be leveraged and how, as well as the sort of how do you ensure this long-term sustainability of public and private outcomes past the third-party support? So at this point in the webinar, we have a little time left here to turn to you for your reflections. And we encourage you to put questions in the chat, to raise your hand. We will make all of the information that we mentioned here today available online. Some of it is already available, and we'll put the link here in a minute in the chat. We will also send you this information to everyone who is registered for this event through the same channel that we did to send the login information. But let me turn now to the audience. I know we have a couple of questions in the chat already, but please feel free to raise your hand at this time. We have one question here asking about how we've worked with private sector associations. I wonder if Dr. Marani or Nelson, if you'd like to jump in and just share some of your thoughts on this. I see there's some responses in the chat.
Thank you, Cicely. I put something on the chat, but just to say that the private sector association and professional associations are also a key partner in the PPE framework. And we, in the case of Kenya, we worked with the Kenya Healthcare Federation, which is the apex private sector association, first to co-create the PPE approaches in Kakamega County and link them and align them to what is happening at national level. And two, when the private providers in Kakamega agreed to form an association to organize themselves and strengthen their voice, we also brought in the Kenya Healthcare Federation to support them with resources, to link them to what's happening at national level, and also as a more long-term supporter and partner to the new association. Thanks.
Thanks very much, Nelson. We have a few more questions here. Is there anyone who'd like to jump in on the line? We have one question here about how to balance private sector interest for profit and public sector resource constraints while trying to facilitate engagement. I'd be curious if Marani, if you'd like to jump in, or Jadev, thinking about these issues that you were working with the stakeholders in India and Kenya. Not sure. Go ahead.
Sorry, I had a bit of a skip in the connection and missed the question. I'm so sorry about that.
The question is how to balance private sector interest for profit and public sector resource constraints while trying to facilitate the engagement.
Sure. So I think at least in the case of India, what was helpful for the engagement, starting off, was an understanding between the public and private sector that they are on a common mission, they are on a common goal, and of course there were questions around what would be the sort of sustainability strategy, and the public sector in this case was limited, in terms of resource, and I think it was really commendable that the private sector has been working for some time now to really make this quality certification program, which is the Lakshya Manata, that it looks at quality certification for obstetric gynecologists in the private sector, as to how that can be turned into a sustainable business model by getting the private sector to really pay for quality improvement. And the value addition for them really comes in when the government recognizes their efforts and possibly in the future seeing how they could perhaps get even an additional incentive to have such quality certification. So I hope that to some degree answered the question. Back to you, Cecilia.
Thanks very much for that.
Cecilia, could I add a little bit?
Please do.
Yes, at the beginning of our engagement, the issue of the private sector being in it only for the profit actually did rear its head. And especially from the government side, it seems to be a hindrance to them because they felt that healthcare should be provided as a social service. However, as time went on and there was more engagement and improved communication, what ended up transpiring is that the government side also started appreciating that the private sector is actually putting up capital to answer some of the health challenges that the county was experiencing. I'll give an example. In an area where the government has not been able to put up specific diagnostic equipment, and the private sector has put up such equipment, it transpired to the government that it does make sense that rather than getting the money to put up a new, let's say, a new ultrasound in a certain area, why not use the private sector and figure out a payment mechanism for it? So it ended up being a win-win situation. And some of these are the collateral outcomes we ended up seeing after the soft factors were taken care of. So that would be my input, Cecilia.
Thanks very much for that, Marani. That's really helpful. I might take this question here from Alix. Your question about how do you prioritize topics to address in public-private engagements when the public and private sector actors may have different views or priorities for maternal and child health? I think this is a really good question, and one that is likely to be the case in many instances. And really where we are learning on this and where we saw an opening for our approach is to bring those parties together to have the discussion on those priorities from the beginning. So even though those priorities may not be exactly the same, if there's a common goal that the group is working towards, we found that that can be successful. So what I mean to say is that when the public and private sector come to the table, they may have different motivations. Private sector may want to be ensuring profit, which would make sense given that they're the private sector. It doesn't mean that a common goal can't be reached for maternal and child health. And so what we found is that it's really this process of dialogue and joint problem solving. So really analyzing the challenge that's there, not just thinking about how to react with a solution, but really thinking about the root causes of the challenge that's being experienced and spending some time on that piece before moving forward in some sort of solution or partnership or engagement to mitigate that challenge. So I hope that gives a little bit of color there. Thanks for all these questions. I think we've got some really, really good ones coming in. I know there was a question up here about transparency. Let's see if, Keith, could you read out that question for us?
Sure, the question comes from Edward Owino, and what was your experience in ensuring transparency in such engagements?
That's a great question. And I'd also ask our colleagues who are working with the partners in Kenya and India to jump in. I think I would just link it to my last point about how we shepherded the process in terms of transparency. There really was a lot of encouragement by the trusted brokers to have these open discussions and to get on the table the issues that were of interest to them. So for instance, in Kenya, one of the issues that came up was really around reimbursement from the National Hospital Insurance Fund and what exactly was happening both for public sector and private sector. And I think being able to have that open dialogue was really very useful. But Marani, Nelson, Jadev, Walter, if you're on the line, if you want to jump in, please do.
Sure, I could perhaps go first, or Nelson, if you don't mind. But just to say, I think Cicely raised an important point. The process itself, in a way, added to the transparency, I would say, because if we look at the engagement factors, for example, these were issues that were probably lurking around, a very diverging view on, measures of accountability and communication. But what happened, using this sort of engagement factor approach is that these really came, out in the open, right? And partners, while it may have been initially surprised that they had such divergent views, I think it added a layer of transparency and dialogue, wherein they wanted to actually get down to it and understand, okay, we seem to have a very different perspective on these specific things. So let's come to the table and resolve these issues. So I think that definitely contributed to it.
Thank you. I think I'll just add to what Jadev has said. In the case of Kenya also, one of the key factors that strengthened accountability is the setting up of forums like, for example, county stakeholder forums, multi-stakeholder technical working groups that were involved in planning for priorities, agreeing on the roles of each party or partner, and then jointly following up to ensure that what was agreed was done, and where there were challenges or there was need for change, it was done openly. So we found the open communication and accountability that was created through the forums, the technical working groups, and various committees helped to improve accountability. The other bigger issue also is that the the setting up of a structured and a regular public-private dialogue forum also strengthens accountability, because all the key issues are brought on the table. The PPE is focused on health system issue and not individual institutional interests, and planning is joint and monitoring is joint. So we saw that as a strengthening accountability between the partners. But again, this is just the beginning. It's something to look how it will evolve with time. Thank you.
Thanks very much, Dr. Katanga. I want to come back to this question from a colleague about, does the legal system allow partnership in all areas, services in the countries we investigated? So I guess the first thing to say there is that certainly the issue of partnership between sectors for services will vary by country. We did, the work we were doing, as we mentioned, is in India and Kenya, and some of the assessment that we did, the integration assessment, got at these issues, but we didn't do a sort of systematic review of legal issues across other countries. So there are some limitations here, and it does vary across the health sector in terms of whether for services or products. Maybe Jadev, I might turn to you to speak specifically about India to this point. I think it came up a little bit in our integration assessment. Jadev, are you still on the line there?
Sorry, yes, Cicely, sorry about that. I'm facing some connectivity issues. Sorry, Cicely, it's just a lot of hiccups. If you could frame that again for me.
No worries. Just thinking about the integration assessment that was done in India, I wonder if there's anything you could share about the legal frameworks and any either mitigating or barriers that came out of that.
Sure. So I think specifically in the case of India, what was an important consideration is how the regulatory environment plays out in a sort of more federal country or a decentralized environment. While Lakshamanata was, of course, being conceived within a subnational context, I think the question around what that would mean if it is really transferred to another setting or a state context was an important learning. But and also to the extent that a lot of that was designed under this program, still needed to sort of be reconciled, with what are some of the national laws and some of the regulations, which aren't specific only to the health sector for that matter, go well beyond it. So definitely taking a much broader sort of view to what the regulatory and legal implications are, even beyond just the health sector, is, I think, a very important a factor that does need to be assessed as part of the integration assessment. Over to you, Cicely.
Thanks so much, Jadev. Elizabeth Hema, I know you're on the line. I see this interesting comment that you've put in here about the experience with networking in Ghana. I'm wondering if you want to share that experience with the group. Elizabeth, are you still on the line? So Elizabeth shared with us that in some work that she supports in Ghana with the preferred primary provider networks, that the broker is not only important for highlighting the common goal, but also the mutual benefits in partnering, particularly for private providers who are there for profits. And she notes that formalized relationships through MOUs have also been used to foster commitment to partnerships. I want to thank everyone for these great questions and comments. We are tracking them, and if there are specific questions that we can get back to, we will do so and follow up with you personally. I'd like now to give it over to our colleague Jackie Caglia from Merck for Mothers Initiative, just to say a few words. Thanks, Jackie.
Thank you, Cicely, and thank you, everyone. I just want to also apologize for the collective experience that we had earlier, and also thank everyone for rejoining and continuing this lively discussion. I think that we all are committed to ensuring that women around the world receive access to high quality maternal health care regardless of where she seeks it. And the learnings related to the public-private engagement in mixed health systems really point us in the direction of realizing that goal collectively. I'd also like to extend big thanks to Cicely, Courtney, Keith, Chloe, and the entire R4D team for their support throughout this effort, as well as our colleagues from India and Kenya joining today, sharing their experiences. Thank you all so much. We have learned a lot, and we hope that these contributions to the field will be continued to be built upon. Thank you.
Thanks so much, Jackie. We've really appreciated the support and the partnership and collaboration from the Merck for Mothers team. It's been a great experience. I want to just go forward to the slide that has our contact information and thank everyone for joining today. We really appreciate you rejoining after that terrible experience, and we'll be sure to contact you all with the information that you can link to our website, as well as with the documents themselves. So thanks very much for your time and have a great day.